Welcome to the Infection Prevention Strategy Tips Masterclass webinar to address N95 respirator use, disinfection, and reuse, what the literature says. We will begin in 2 minutes. Welcome to the Infection Prevention Strategy Tips Masterclass webinar to address N95 respirator use, disinfection, and reuse, what the literature says. The highly transmittable nature of this novel virus and the exposure risk associated with it are evolving daily. Understanding the most recent updates on COVID-19 is essential as we implement recommended processes and procedures from government and regional health authorities for hand hygiene, the use of personal protective equipment or PPE. These recommendations will provide maximum efficiency against the virus while maintaining a safe environment for our staff, patients, and customers. My name is Dan Mueller. I'm the Senior Vice President for Curcia Medical. I'm also an advisory board member for TIPS. By participating in this webinar, you acknowledge that the statements and information provided is for general guidance purposes only. The coronavirus situation is evolving and dynamic. You are advised to contact your local government and regional health authorities for specific instruction on all the topics mentioned in this webinar. This webinar is not to replace the guidance and direction of your local government and health authority. The learning objectives for today are posted on the screen for your convenience. I'll let you read through those briefly. Our first speaker will cover the first 3 points, and our second speaker will cover the next 6. This presentation will last 50 minutes, followed by 10 minutes of Q&A. This event will be recorded and available for viewing in the next few days on the TIPS website. Participant lines have been muted. Unfortunately, continuing education or CE credits are not available for this event due to the limited time. The webinar series is hosted by TIPS. TIPS is a non-for-profit organization existing to advance innovations, ideas, and processes which make a difference in global health. TIPS extends to over 30 countries and is the key strategic partner for many notable organizations, initiatives, and events. In the past few years, TIPS has contributed millions of dollars worth of scientific impact through various programs. Many of their successes are published on their open access journal, infectioncontrol.tips, at conferences, itsconsortium.org, on their masterclass events, masterseries.events, and discussed on their podcast. Please visit the TIPS COVID resource page, which includes the such but not limited to the N95 mask, disinfection methods, protocols, articles on COVID-19, links to global resources, as well as participation from industries. There are daily new validation of protocols and approved devices specific to this topic, and TIPS will be updating this portal on a daily basis. I also want to recognize Michael Diamond, the co-founder of TIPS, who organized and helped pull this webinar literally within 1 week. Normally these events take months. It's really incredible, especially with today's situation. So thank you, Michael. We have you muted, but thank you for all your help to organize. The webinar today is sponsored by Corsia Medical, which makes NADCC disinfection tablets, which release hypochlorous acid when dissolved in water. Their EPA-approved claims include as a sporicidal on the EPA list of emerging pathogens, virus, SARS, coronavirus 2, and also EPA-approved for surface biofilm. So thank you for the sponsorship. For any questions, please type your questions in the webinar panel labeled Q&A. We will follow up after the webinar to address any questions we're not able to answer during the webinar. And we will post these on the TIPS Resource Center portal. Without further delay, let me introduce today's speaker. First, Dr. Katie Morales. Dr. Morales has over 30 years experience as a registered nurse. Her practice areas include adult medical, surgical, orthopedics, emergency department, and intensive care. Her dissertation focused on the role of patient hand hygiene in healthcare-associated infections. Next, Professor William Anderson. Bill Anderson is a professor of chemical engineering at the University of Waterloo in Canada. He has been active in research on UV-driven photochemical processes for almost 30 years, including air, water, and surface disinfection. Other industry-sponsored research topics include antimicrobial materials, rapid detection of microbes in water, and capture of anesthetic gases from hospital air emissions. Without further delay, Dr. Katie Morales.
Thank you, Dan. So I also would like to echo my thanks for putting on this presentation. It started as I was speaking with Dan about another presentation, because I was getting contacted by so many nurses that are practicing with concerns. So I just want to reiterate that no matter what PPE we're talking about, it does not replace the simple measures we can all take, such as respiratory hygiene, coughing into your elbow or into a disposable tissue, hand hygiene, which I have bolded every time it comes up in my talk because it's so vital and so overlooked. And then finally, the T-zone touching, not touching your eyes, nose, or mouth. But when we talk about personal protective equipment, we're referring to clothing or equipment designed to protect the personnel from hazards. And so this is a picture of a common PPE station that might be on a patient's door in the hospital setting. PPE is the last line of defense between the hazard and your personnel. So the first step is to address any workplace risk or hazards first, and then remember that PPE does not replace any of those simple measures that we could take. The problem that we're seeing and is being reported to me is that the N95 respirator supplies are being depleted during this pandemic. And so thankfully there are existing guidelines recommended, and this recommendation is for a multimodal approach to conserve our supplies while safeguarding the personnel. And I did focus a lot on the Centers for Disease Control, or CDC guidelines, but I also looked at guidelines from other countries and synthesized the information for you. So as we look at this, I think maybe because I have a degree in philosophy, but we're seeing a moral dilemma for most of the healthcare workers. And one of my favorite theorists would call this the tension of the paradox. We want to be evidence-based, but we're in a novel situation. So we're having to be innovative at the same time. And the guidelines say, assume everyone is infected, including yourself, but then we're limiting PPE. So it's a little conflict for the healthcare worker. We teach students to ask, is the scene safe? That's the first question. So if we don't have our PPE, is the scene safe? What about rescuer safety? And then finally, adding to the dilemma is, should patients be informed that we are extending use or reusing supplies? So we want to be transparent, but these are the dilemmas the nurses are facing and other healthcare workers as well in the middle of this pandemic. So this started with the feedback that I was getting from nurses currently providing care here in the Southeast US. Perhaps you can tell I'm from Georgia, probably tell from my accent. But common things that I was hearing is rationing of the PPE, especially the N95 mask. And one nurse was saying they only get one mask per week. Another one said we get one per day. And another one said we get one mask every 2 weeks. And then yet another nurse said they have to use the same one until it's damaged. And when it's visibly damaged, they can get a new mask. Another facility is reusing for 8 to 12 hours on one patient. And then these were some questions or other practices that came up. If caring for multiple patients, can you place a surgical mask over the N95 and discard the surgical mask, which seems to be pretty common. One nurse expressed a fear that storing the mask could contaminate the clean side, so the side that's closest to the face. One hospital does have this beautiful, it looks like a toaster oven. It's very small, UV disinfecting unit, and they were putting their mask in there. And then they were told they had to stop because it could harm the fiber. So there's confusion as to the safety of that. And certainly Dr. Anderson's going to tell us more about that. And then another hospital said, well, if the virus dies in 3 days, could we wear the mask, put it in a bag at the end of the day, and then 3 days later wear the same mask again? Because in theory, the virus should have died. So these are the questions that our healthcare workers are truly grappling with in the middle of this pandemic. Then some other stories that were not relayed to me firsthand, as those were, these came to me more secondhand, so you lose some fidelity. But somebody sent me a little snippet that said you could sterilize your mask in an oven at 77 degrees Celsius or 170 degrees Fahrenheit for 30 minutes. And then Dan was telling me about one place that was wanting to use ethylene oxide. So I would just caution you that anything you try to clean the mask with, you're going to be inhaling for extended periods. So you just want to make sure of the safety. There have been stories of nurses and healthcare providers that had to make their own private purchases because they didn't have N95s at the hospital. And then there are stories where nurses are being fired because they're bringing in their own private stock. You're seeing plenty of public donations. I know my school donated our PPE from the simulation lab to the hospital locally. Some schools are using their 3D printers to make equipment for hospitals. And then finally, you're seeing more and more homemade PPE. And then you probably saw the headline where a nurse in New York was using garbage bags for PPE, and that nurse sadly was infected and died. So the current recommendations, I think this is part of the dilemma. Initially, they put everybody on airborne, and then as PPE got more scarce, they said, well, we could probably put everybody on droplet and contact precautions for routine care with just a surgical mask. So that's the mask pictured there. And save airborne precautions for aerosol generating medical procedures, which would be suctioning, tracheostomy care, those high flow nebulizer treatment, those types of things. And in that case, we need the N95 mask because it's much more fine. And all the studies say last resort would be any unapproved, unevaluated, or homemade mask. So let's just talk briefly about homemade masks. There's not a lot about this in the literature. We did look at some studies. And the bottom line was a homemade mask is better than nothing. It does not eliminate the risk, especially if there's more than one route of transmission. It offers little protection from microorganisms from people that are infected with respiratory diseases. It's not recommended to reduce transmission from aerosols. And again, just any mask will have minimal effect if it's not used in conjunction with other preventative measures such as isolation of infected cases, respiratory and hand hygiene, and avoiding the T-zone touching. And just my personal synthesis of the literature was that homemade masks seem to do a better job of keeping the germ in than keeping it out. So if you cough and sneeze, it helps hold that in. But if you're coughing and sneezing around me, a homemade mask won't protect me from breathing in what you're coughing and sneezing. So if you're seeing plenty of groups that are starting to make masks to donate to hospitals, and if you're going to make masks, you just want to make sure you're looking at a reputable source as to how to make the mask. So there's two sources for you right there. So we do have contingency guidelines because this is not our first pandemic, but we want to prioritize and the use of the N95 respirators for those personnel who are at highest risk of contracting or experiencing complications of infection. So we want to minimize the number of individuals who need to use the respiratory protection by keeping dedicated personnel in a dedicated area. We want to implement practices allowing extended use or limited reuse of N95s and use the N95s for personnel who need protection from both airborne and fluid hazards. So the contingency guidelines do recommend using a face shield or some other kind of shield over your N95 and using alternatives to N95s. And so these illustrations here are alternate masks for, if you don't have an N95, these would be other acceptable masks. So if we're using N95s, we need education. I had a friend that contacted me and said, don't worry, I bought my own N95. So I said, were you fit tested? And she had no idea what I was talking about. So an N95 will only protect you if it's properly fitted. So we want to make sure our personnel know when to use the N95 and how to use it. And then we might need to do just-in-time fit testing, which is large-scale evaluation, training, and fit testing of personnel. So this is a picture of fit testing where they put the little helmet over, put the mask on, and they spray like a saccharin-type compound, something very sweet. And if you can taste it, then those particles are coming in around the mask and it's not a proper fit. So let's just make sure we know what we're talking about when we say extended use. Extended use is when you wear the same N95 respirator for repeated close contact encounters with several patients without removing the respirator between patient encounters. That's what really distinguishes it from limited reuse. It may be implemented when the multiple patients are infected with the same pathogen and placed together in a dedicated area. And it has been recommended as an option during previous pandemics. So we do have some precedents to look at in this. Compared to reuse, which is using the same N95 respirator for multiple encounters with patients, but you do remove or doff it after each encounter. And in between uses, it's stored to be put on again later, which is called donning, prior to your next patient encounter. There are restrictions which limit the number of times the same N95 respirator can be reused. And because of this, reuse is often referred to as limited reuse. And this has also been recommended and widely used in the past to conserve respirators during previous pandemics. So the decision to either have extended use or limited reuse should be made by professionals who manage your institution's respiratory protection program in consultation with your occupational health and infection control departments and with input from your local government and regional health authorities. These decisions are made on a case-by-case basis, considering not only the respiratory pathogen characteristics, but the local conditions. So extended use recommendations. Extended use is actually favored over reuse because there's reduced touching of the respirator and risk of contact transmission. However, you must maintain fit and function of the mask. And this has been studied with personnel in other industries who routinely use N95 respirators for several hours uninterrupted. There was a study, and within that study, it's the function the N95 was able to function within the design specifications for 8 hours of continuous or intermittent use. And there were some studies with healthcare workers that indicated many successfully wore an N95 at work for several hours before needing to remove. But what I didn't see was what did many mean and what were several hours. And we're talking about the average nurse works 12 hours, 12-hour shifts are very common. I didn't really see those numbers spelled out for me. So rather than having a predetermined number of hours, maximum length of continued use in a non-dusty healthcare workplace typically is dictated by hygienic concerns, such as whether the mask is contaminated, and then practical considerations. So when the healthcare worker needs to doff the PPE to use the restroom or take a meal break and those types of things. So with extended use or reuse, we have no way to determine the maximum possible number of safe reuses that we could just say this is a generic number to be applied in all situations. So the variables which impact function and contamination are administrative and engineering controls, which we'll look at in a second, and barriers to prevent droplet spray contamination, minimizing unnecessary contact with respirator surface, and then the PPE donning and doffing technique. So I know this is something we go over with our students a lot, and I think we get a little sloppy in the workplace, to tell you the truth, that there's a proper way to put it on and a proper way to take it off, and that is based on studies to prevent contaminating yourself. And then regardless, it's strict hand hygiene after you take it off. So here are some administrative controls, and you're seeing this in hospitals, I think across the world now, but excluding visitors, limiting the number of patients that are going to hospital or outpatient settings, reducing those face-to-face encounters with patients. And I'll just say, we're very fortunate if you look at the pandemic of 1918 compared to this one, we have social media. And so many just brilliantly simple ideas are being shared on social media. So we have that advantage. Source control of patients, asking the patients to wear a face mask, cohorting patients together, keeping all the infected patients in one area, excluding personnel who are not directly involved in patient care to minimize exposure, cohorting your personnel so that you have a designated team to care for known or suspected cases, excluding personnel at higher risk from contact with known or suspected cases. This is a problem for us because if you look at the age of the nursing workforce, it tends to be an older cohort. So the very people providing care are in a higher risk group. And then convalescent personnel. We really don't know, but it's suggested that clinically recovered people may have some protective immunity. So keeping those personnel together as well. So engineering controls include physical barriers. You're seeing this more and more with sneeze guards, like at the grocery store or at the post office here. They have clearly marked off 6 feet with tape on the floor, and then they have clear plastic from the ceiling to the counter so that you're not having direct face-to-face contact. Putting your patients in airborne infection isolation rooms, or if you don't have those, expedient patient isolation rooms. Ventilation systems, such as local exhaust ventilation or a ventilated headboard, which is what is indicated in this photo here. So what are the recommendations before you use the N95? First, we want to make sure we're following the manufacturer's user instructions for the maximum number of donnings, inspection procedures, and conducting a seal check. If we don't have any recommendations from the manufacturer in an ideal world, which I understand a pandemic is not ideal, we want to limit the number of reuses to no more than 5 per device. So here is an example where in the paper bag that they store it, they put 5 little boxes and they check it off each time they use it. We want to perform hand hygiene before and after touching or adjusting the respirator, and wear clean gloves when donning a used N95 respirator and performing that seal check. Part of the inspection would be looking to see if the straps are stretched so much they no longer provide enough tension for the respirator to seal properly on your face. or if the nose piece or other fit enhancements are broken. So this slide is just an example of one manufacturer's recommendations for how to apply the mask and how to perform the seal check. So basically, once you have the mask on, when you breathe in, it should actually kind of pull the mask towards you, and when you blow out, it should push it away to show that it's tightly fitted. So recommendations for when you're wearing the N95, we want to make sure that respirator is sitting comfortably on your face with a good seal. We want to discard those gloves after your N95 respirator is donned and you've made any adjustments. And then always avoid touching the inside of the respirator. If you should inadvertently make contact, you want to perform hand hygiene. So here's some recommendations after you wear the N95. They are meant to be single wearers. And believe it or not, I read somewhere, it was online, I'm not saying it was a research article, where they were actually promoting, like, say, people sharing an N95, which is totally, would be like the worst case scenario. We want to label the storage containers with the person's name, so that, or you could write on the straps of the N95. You do not want to write across the front on the mask part of it. You need to store the respirators so they don't touch each other and they're not damaged or deformed, and hang them in a designated area or keep them in a clean, breathable container, such as a paper bag shown here. The storage containers themselves should either be disposed of or cleaned regularly. And then, of course, perform hand hygiene. So our biggest risk is contact transmission. We know that pathogens can remain on the respirator surfaces. We can have microbial transfer or re-aerosolization of the pathogen. And the good news is they're made to trap pathogens, and this suggests it does. 99.8% remain trapped on the respirator. So they're still there when you handle them, or they remain trapped after you cough or sneeze as well. And the way we're gonna contaminate, your contaminated hands will transmit the pathogen is either to yourself via self-inoculation, which is touching your T-zone, your eyes, nose, or mouth. And I know there's been several videos of people saying, don't touch your T-zone, and within the time that they're saying it, they're touching their own T-zone. So we all do this, we're all guilty of it. One study found that nurses touch their T-zones 25 times per shift. So, or that they touch the N95 respirator during extended use. So again, that would be the most contaminated area. We can transmit this to others via direct or indirect transmission. Direct would be through direct contact with another person. Indirect is by touching and contaminating surfaces that then other people will touch. And then we also have to consider that the healthcare environment has several environmental pathogens that your mask could get contaminated with if you laid it on a surface. And there are certainly many multi-drug resistant organisms in the average healthcare setting that is not properly cleaned and disinfected. So then other risks we have to consider is reduction in the ability to protect the wearer by rough handling or excessive reuse of the respirator. And then discomfort, which doesn't sound that big of a deal, right? Like, oh, too bad, it's uncomfortable. But no, this is a big deal. You're seeing more pictures like this. This is just one I found on the internet where the healthcare workers are almost having pressure ulcer type injuries from having to wear the mask for extended periods. So it could be a rather serious thing. And we know that if it's horribly uncomfortable, the risk of adherence is going to go down. So let's just finish this part up with when to discard your N95 respirator. So following use during aerosol generating procedures, it should ideally be discarded. If it's contaminated with blood, respiratory or nasal secretions, any bodily fluid should be discarded. Following close contact or exit from a care area of any patient co-infected with infectious disease requiring contact precautions. Anytime it's obviously damaged, and if it becomes so hard to breathe through, then you're going to need to throw it out, because obviously we need to be able to breathe. These are just some selected references that I had for my portion, but I'm going to turn it over to Dr. Anderson now.
Thank you, Katie, for that nice overview of the N95 use and reuse, etc. I found it very informative since I don't work in the healthcare industry. But what I'd like to do in my section is talk about something I do know about, and that's UV and disinfection. And what I've learned in recent weeks about the potential for using UV for disinfecting these N95 respirators. And so just a brief outline, we'll look a little bit at how UV works, just to provide some background information, and so everyone's coming from the same page. And then we'll look at what is published in the literature about N95s and their disinfection with UV, especially trying to focus on efficacy with respect to viruses. And then a big question that's come up is, does UV actually damage the N95? So we'll look at that. And then going forward, review a few issues that need to be thought about before attempting to use this process. And then we'll wrap up very briefly with some discussion of a few things that have come up also about microwaves, heat, and hydrogen peroxide. Just to cover the bases, I do research in UV, but I have no financial or commercial interest in this topic. So this is unbiased as best I can. And of course, this information, as Dan said at the start, is for informational, educational purposes. If there's any regulatory or legal liability issues, those are kind of up to you and your locality to take care of. That's beyond my scope of knowledge. And today I'm not able to provide any specific detailed recommendations for how to do these things. It really depends on your specific circumstances, the equipment that you have, the layout of the equipment, etc. And certainly if you're thinking of using UV, you should probably contact your equipment provider for some assistance with some of those implementation issues. And of course, as Katie said, ideally one should be using a new N95, but what we're talking about is essentially managing risk in the current environment. And so the new N95 is the best case, having no protection whatsoever is the worst case. And so the disinfection processes are somewhere in between. And the thing to highlight is that disinfection is by no means guaranteed to be 100% effective. And so we're really talking about disinfection at levels of 90, 99, 99.9%. And so you have to kind of put this together in the context of risk management, sort of what are you aiming for? How far do you feel that you need to go to manage your risks? And that's, again, an institutional decision kind of beyond our scope. So a bit of review about germicidal lamps. As illustrated in the left-hand side is kind of a typical picture of a type of germicidal lamp, and I'm going to focus today on what are called low-pressure mercury lamps. Oops, sorry. And just a moment here. And they essentially look like fluorescent lamps, and they are actually a version of a fluorescent lamp. They're a mercury discharge lamp, and they typically, when they're turned on, have a bit of a blue glow, but actually most of the light coming from them is invisible because it's in the UVC wavelength range, or more specifically, it's 253.7 nanometers wavelength. And over here, we've got sort of a schematic of the light wavelengths, light spectrum. So we're talking about UVC, which is over here in the ultraviolet range. Again, the lights do put out a little bit in the blue and kind of indigo violet range, which is why you can see a little bit, but a lot of the light is coming out, which is invisible in this range. And just to point out, the farther to the right you go, the more energetic the light is. And so beyond the far vacuum region, you're starting to get into the X-ray region. There are other UV systems used for germicidal purposes. There's xenon pulse lamps and sometimes in water treatment medium pressure UV lamps. And they're certainly germicidal, but they're different in the sense that they put out a whole bunch of wavelengths of light, both in the UV and the visible spectrum. And I'm not going to really talk about these at all. There is no literature that I found on these types of UV sources with respect to N95s. There is literature on other applications, of course, but they're kind of not in this scope of the talk. And there's also, as many people might be aware, UVA tanning lamps and phototherapy lamps. Those typically have wavelengths around 360, give or take. These do not work for disinfection, especially not for N95 disinfection. There's references which are at the end of my talk, which you can look at later. But definitely do not attempt to use tanning lamps for this purpose. It will not work. So the UVC is what we want, and I'll round it off to 254 nanometers. But how does that work? Well, essentially, the UVC is strongly absorbed by DNA and RNA molecules. And what essentially happens is that it disrupts the molecule, what's called photodimerization, and cross-links the DNA and RNA at various places. And that essentially prevents the DNA and RNA from transcription, translation, etc. So the microbe or the virus is essentially unable to function without the DNA being in a functional form. So that causes the germicidal action. In terms of UV, there's kind of the key thing is the UV dose, which is often cited in terms of millijoules per centimeter squared. And that dose is the product of two things, one of which is irradiance, and typically in milliwatts per centimeter squared, and then time. So it's essentially intensity and time. And so for a given desired dose, you can either have a high intensity or high irradiance in a short time, or you can have a low irradiance at a long time, but ultimately you're looking for a certain dose to achieve the germicidal action. And the irradiance itself depends on the lamp power, as illustrated by the circle here, or possibly there's multiple lamps. And then the distance from those lamps to the target that you're trying to disinfect. And so if the target is close, you'll get a higher radiance. If it's farther away, you'll get a lower radiance. And if there's anything in between the lamp and the target, which causes shadows or absorbs some of the light, that will also reduce the irradiance. So these are all things that need to be considered when putting together a system. In terms of the doses, there is literature showing germicidal doses for various organisms. A few examples are shown here focused on viruses, and these are doses required for 90% disinfection, which is a way of sort of comparing and contrasting different things. And so there's the couple of coronaviruses. This is the sort of first SARS from 15 years ago. Influenza, polio, adenovirus, etc. And so one of the things to notice is that the required dose to get 90% disinfection can vary quite a bit between different viruses and different microbes. But it also varies depending on the medium. And so we see some of these are in air, some in water, some on surfaces. And so it gets a little bit complicated to come up with a recommendation for a dose because of the variation between viruses and between media. It's challenging. And the bottom line is that there actually isn't a whole lot of data for viruses, especially in air or on surfaces. In water, there's somewhat more, but these other media are not so prevalent in the literature. The other thing to note is that when you're looking at dose requirements in literature, which are reported for surfaces, those are usually based on sort of this upper schematic, where the amount of UV that you apply is essentially what hits the virus on the surface. So the applied dose is essentially equal to the received dose at the surface. In the context of N95 and other filter material, that is not the case. And so we may apply a certain dose on the outer layer of our filter, but as that UV is transmitted through the material, you lose some of the UV intensity or the irradiance due to absorption by layers and reflection and refraction process, etc. So the dose that you apply at the surface may be quite a bit different than what you actually end up with on the inside of the mask. And so that's a very important consideration. However, there is literature on N95 disinfection with UV dating back roughly 10 years, where they were doing this work in anticipation of potential pandemics where they might have to reuse N95 masks. So this information has been around for a while. At the time, they did some work with mainly influenza viruses, and MS2 is a bacterial virus, essentially a coliphage. And we see that the doses that they required on the surface of an N95 were kind of in the 1,000, 2,000, 4,000 range. And they were applied in different ways as summarized here, sometimes just on the convex side, this outer surface, sometimes on both sides. So there's a variation in how it was done. But generally with doses in this ballpark, they were getting efficiencies of disinfection which were pretty good, 4 nines, 3 nines, etc. I also put here, just as an example, a bacterial spore, which is also susceptible to UV, although typically spores require a bit more of a dose to get decent disinfection. So that may be a consideration for an application. If you're in an environment where spores are potentially present, and I'm thinking of C. difficile, for example, this might be something that needs to be taken into account. So what we learn from the data that's available is that you can disinfect these N95s. You can do it from one side and get pretty decent disinfection, at least for influenza. There is other literature that suggests that the N95s capture about 90% of the aerosols on the outer layers of the mask. So dosing it from that outer layer makes some physical sense. But penetration to the inner layers is key to getting overall good disinfection. And there is literature that shows that different mask models have different numbers of layers and different materials in the layers, etc. And so there will be some variation between the models and manufacturers, which needs to be taken into account. And so from that point of view, possibly irradiating from both directions would be desirable, and it possibly results in a lower total dose than trying to get it all from one side. But these are, again, kind of design considerations that could be taken into account when one sets up a system. So the other key question is, if you do the UV radiation, will it affect your N95 performance? And there's kind of two issues that are looked at in literature. The filtration obviously is a key one. The N95s are supposed to achieve at least 95% removal of particles. And if they lose that ability, then you lose your protection. The other thing too is fit. If you lose the fit, as Katie said, you lose some protection, and then usability in terms of airflow resistance. If it becomes harder to breathe, then you're not going to want to use it. And the good news is that there is a fair amount of literature which has looked specifically at UV damage to these N95s, and it's summarized here. Various reports have looked at different numbers of models and manufacturers, etc. The one perhaps of most interest towards the bottom here, where they applied doses of up to 20,000 millijoules. And if you think back to the previous slides, typically a required dose for disinfection is maybe around 1,000. So this is at least 20 times more than what you would need for one round of disinfection. And at this massive dose, they found no effect on the filtration performance, no effect on the fit or the airflow resistance. They did note that the straps start to lose strength once you get to about 10,000 and onwards. So that, as Katie said, is potentially something that needs to be watched out for if you're starting to break the straps, obviously, or losing tension in the straps. But I think the bottom line is that UV does not damage the performance of the mask, certainly with UV doses which are quite high. And that also makes sense in terms of other literature. The filter material itself is typically made of polypropylene, which is well known to be quite UV resistant. Potentially it affects performance, but it takes massive doses well beyond what one would normally do. The effects seem to be seen on the straps first before you start seeing any other effects, and so that's kind of an early warning. And I couldn't find any information where there was an effect on the filtration performance or the fit, and so those are kind of the key things from a protection point of view. So if we looked at sort of doses in the range of 1,000, that would suggest you could maybe reuse it and repeat that dose 10 times with no performance effects. Of course, there's other reasons why you might not want to reuse it 10 times, but that provides some level of safety and comfort. What are uncertainties in terms of UV disinfection applications? Well, first of all, I haven't seen any information on the susceptibility of this specific coronavirus to UV. We might imagine that it's similar to the other SARS coronavirus and possibly other influenza, etc., but that's a speculation. Are there other potential pathogens, bacteria and spores? Then those need to be perhaps considered. The soiling effects on the disinfection have been tested to some extent, but it's not clear to me that it's been extensively tested, and it certainly hasn't been tested in the field, if you like. And there's lots of evidence that would suggest that if it is heavily soiled, visibly soiled, that will reduce the UV transmission into the mask. And so a recommendation would be to reject visibly soiled face masks, as Katie said earlier. And there will be variations in treatment efficacy between different models and manufacturers, again, because there are different thicknesses of the filter layers and number of filter layers. And again, the literature has tested this to some extent, but I'm not sure whether there's other ones that needed to be tested or whatever. And are there upper limits to disinfection cycles, possibly related to soil buildup on the mask as they're repeatedly used? You might start losing airflow or getting increased resistance to airflow as stuff builds up, which is disinfected but still provides a resistance to airflow. So again, there's probably some limits which need to be thought about. In terms of the equipment, there's everything from simple to more complex systems. Over on the right-hand side, kind of just a simple lamp assembly where you set up UV germicidal lamps and stick some masks underneath and irradiate them for a period of time. There's kind of a tunnel device in the literature where they stuck masks in here. And I understand there may be commercial versions of this around with a sort of conveyor belt, so you can kind of have a continuous irradiation process for masks. Other literature, they've used biosafety cabinets, which often have UV lights installed in them, and just put your masks on the surface there. So those are kind of the range of simpler devices, perhaps. Some hospitals have these UV disinfection towers, which are used for room disinfection. And so there are thoughts of using those for mass disinfection. And Nebraska Medicine has a document circulating where they've set up in a room 2 towers like this, and then essentially a clothesline between the two with masks that then get irradiated from both directions. And so that seems like a possibility. And then another one which one might envision from a sort of radiation engineering point of view, just putting a screen of some sort where you can hang up masks on, relatively close to the tower, so you get fairly high irradiance from one side at least, and fairly uniform too, given the annular configuration. So again, there's no literature on this, but this is kind of a conceptual idea for using a tower if it's available already. Any system which you look at setting up needs to be done very carefully and with calibration. And so that requires radiometer measurements or some other kind of dose measurement to make sure that you're getting the dose that you're aiming for at the surface of the N95s. And again, UV equipment suppliers can probably provide input and assistance with those sorts of things. And then the other aspect is it would be useful and recommended to have some sort of experimental validation or some sort of QA/QC process to make sure that sort of on an ongoing basis you are getting good disinfection. This again would have to be developed at a specific site, considering what facilities and laboratory protocols are available, but one might imagine testing masks, a few masks randomly sampled before and after UV radiation to see what sort of bacterial loads they have. If the bacterial load doesn't completely disappear after disinfection, then it might be an indication that it's not working as well. So that would be one thought. To wrap up, just a quick look at microwaves. There's a little bit of information and literature on those. The first thing to say is don't put the N95 in the microwave and turn it on, it will melt it. That's been documented. But the place where it does work is in a setup illustrated here, where there's a mask sitting on a box with some water in it, and the box had perforated lid, and they radiated it for 2 minutes at this power level, and the box contained this amount of water, 50 milliliters at 22 degrees Celsius initially. And at least for influenza, they measured a 4 nines disinfection, which is pretty good. So that is a possibility. The obvious drawback is that that's just one mask at a time, so the scalability is a bit problematic. If you're using a microwave oven with a lower power rating, you need to increase the time, and so that needs to be considered. And there hasn't been a lot of work done or published where they change the amount of water or the initial temperature or the surface area of the water. And so one can only say that it's good at the conditions specified in the previous slide. If you deviate from those, who knows what will happen. So that's kind of a critical thing that needs to be looked at or considered. And again, it's only been tested with influenza. Whether there's differences in susceptibility to this process with coronavirus, I wouldn't know at this point. So this is really not a scalable solution, but for kind of emergency or individual use, it might be an option. Another one is heat treatment. Katie mentioned one thing that's circulating. There is information that the previous SARS coronavirus would be inactivated after holding at about 60 Celsius for periods between 20 and 90 minutes, and it really depended on the nature of the fluid that it was in. These were in fluids, the protein content, etc. So that does provide some information, but not quite relevant to N95s. There is a bunch of data on influenza viruses on N95s where they did hold them at similar temperatures, sort of 60, 65 Celsius for similar amounts of time, and did get pretty good disinfection. So that might be an option. In terms of the performance of the mask, 3 cycles at 60 degrees and 80% relative humidity didn't find any effect on the performance in terms of filtration and fit. So there is some evidence that this could be repeated at least 3 times and be okay. So this might be another option to explore further. This sort of heat treatment probably is more scalable if there's hot heat sources or ovens around that could be used for that purpose. The thing to say, however, is that the polypropylene in these mask materials is really only good up to about 80 degrees Celsius. And so I would definitely want to be very careful not to overheat the mask. You will start to lose potentially filtration performance or increase the airflow resistance. And so that's something that needs to be carefully looked at. Finally, just a couple of comments about vaporized hydrogen peroxide. There are commercial processes around that do this, and there's some recent approvals for doing it on masks. I don't really have too much to say about these. They require specialized equipment generally, which if you have it, fine. You should contact the provider. If you don't, then maybe something to consider, but I don't really have anything further to say on this point. And so in terms of broad conclusions from the UV side, the disinfection is fairly proven in concept, doesn't seem to have any effects on the mask performance until you get to very massive doses. And of course, implementing this idea is going to require kind of a site-by-site work to set it up and to validate it, etc. And heat treatment might be something to look at, but again, further validation is required. And so that brings me to the end of my part, and thank you for listening, and I guess we will turn it over to Dan and invite questions.
Hey, actually, this is Katie, and we're going to take some questions. But before we get started, we're going to ask if you have any specific COVID-19 topics you'd like to see in future webinars, please type that into the Q&A section so we can consider other webinar programs that are helpful. So I think Dan mentioned an upcoming webinar is, what are you taking home? So it's going to look at the risk of transmission from healthcare workers going back home. So I just, again, want to thank Dan and Michael, Curcia, and Tips for doing this webinar. It started because I was contacted by so many nurses with these concerns. So just thank you for being so receptive and so timely in your response to put this on. So we'll get right to the questions and answers. And the first one for you, Bill, I'm just gonna ask this one. I have to scroll back up to it. Somebody just said, bottom line then, does UV disinfection degrade the mask? And if I heard you correctly, Bill, you're saying, does it degrade the mask or the filtration, but it could affect the straps and the fit, and in that case, it would need to be discarded. Is that true?
Yeah, all the literature points to the fact that eventually it will degrade the mask, probably starting with the straps, but the doses required to get to those levels are massive compared to what you really need just for disinfection. And so my takeaway from this is that you can certainly go through a few rounds of disinfection with UV before you start getting or expecting any sort of major problems with the straps. Now the straps may wear out just from use, aside from the UV, so that's a different thing. But my takeaway is that massive doses are required, much more than you would ever use for an actual disinfection.
Okay, thank you. And Ben was asking the slides that you had about UVC, which surface was the UVC tested on? What kinds of surfaces?
That's a good question. I would have to go back and look at the specific literature. Typically, it's on metals and plastic and things like that. But the surface can make a difference in the response too, and that's why you see different numbers published in different references for surface disinfection.
Okay, thank you. I see several questions that are asking about different chemicals to clean the mask. And I think what we would say as a group would be, first of all, look at your manufacturer guidelines as to what kind of disinfection would be appropriate for their product. And then any chemical that you put on the mask, you also need to look at that manufacturer's guidelines to see if it's safe to be inhaled. So would you add anything further to that, Bill?
In terms of the N95 masks, definitely do not use alcohol or other organic solvents because it will affect the filtration properties, and that's documented. Other chemicals like bleach or hypochlorite or things like that are a possibility, but I really haven't looked strongly at that. And so, as you say, to contact the manufacturer would be the best thing.
So, and I will just echo again, so it might not harm the mask, but then we have to think about inhaling it. So there's two things to consider there, whether it's going to harm the mask and then will it harm the wearer as they inhale the trace chemicals left on the mask. So I'd be cautious about chemicals myself. That's just my personal opinion. We had a question about the heating of the mask. Should we be concerned about exhaust from an oven if the masks are being heated in an oven?
That's a good question. I haven't seen anybody address that issue. No, I guess I can't comment. I would certainly, that would be a good question to consider. And where the oven actually ventilates to would be something to look at.
So thank you, Bill. I will say that this is part of the comments that I'm reading for future webinars. Because this is a novel virus, we don't know a lot. Like, we're trying to be evidence-based, but we're having to be innovative. And the comments are, let's do a future webinar on some of these psychological, which is what I mentioned at the beginning, just the dilemma that we're in as healthcare workers. So I appreciate your transparency on that.
Yep. I will say though, based on what you said, Katie, once the aerosols are captured in the masks, the chances that they're released in just sitting in an oven is probably fairly low, unless they're like ruffled around or vigorously agitated in some way. But so I think the probability of stuff being released and re-aerosolized might be low, but that would just be my initial impression.
Good, thank you. So here's a question from Ben. He said, UV causes photooxidative degradation of the polymer chain, creating free radicals, thus changing the molecular weight, such as oxidation of polymers. This plagued the ortho implant industry with breakdown of heavyweight, high density polymers in the 90s. This was from room air. How is it possible that there isn't damage to the polymer chain with UVC is what I believe he's asking.
Yeah, that's a good question. I've looked up some literature on UV effects on polypropylene itself, and it does degrade the polymer eventually, but the doses that they're using are hundreds of thousands of times what we're talking about for disinfection. And that is in part because polypropylene does not absorb UVC very strongly. When you get into some other wavelengths, like the vacuum UV, it does somewhat more. But at UVC wavelengths, it doesn't absorb all that strongly, and anything that doesn't absorb also doesn't react all that quickly. So, so it's really a matter of scale. Definitely over time, and we see this just outside in the environment, over time stuff exposed to sunlight breaks down, but we're talking about low intensity over periods of years, versus for disinfection we're talking about higher intensity but only for a few seconds or a few minutes. And so it's really just a relative proportions is the issue here.
Okay, thank you. There's a question that said, and I think I'll answer this and then ask you for your comments, Bill. Who makes the decision if the mask is good or not? So in other words, should it be sent for sterilization or disinfection? And I would say we don't have guidelines on that, but I would think if the wearer who put their name on the strap, you know, saw that it was not visibly damaged, not visibly soiled, and they sent it, they certainly have a vested interest in not sending a mask that they believe is damaged. So I would think probably the wearer would decide that. What would you think, Bill?
Yeah, certainly the wearer would have good insight into how well it seems to be fitting at the end of their shift or whatever. The other thing I would also say is that the wearer would also have pretty good insights into whether the mask has been soiled in any way that's going to cause concern, especially with kind of proteinaceous type materials, which will absorb UV quite strongly.
Okay. Somebody asked, if we don't have access to UV, is the steaming or oven method the best alternative? And let me ask you along with that question, because on social media, some people were suggesting if I didn't have UV, could we be getting it from barbershops and nail salons that have the smaller UV units to disinfect their equipment? Could we be putting masks in those, borrowing those and using them during this pandemic? So I'll throw that to you, Bill.
Yeah, in terms of kind of using UV systems that you find here and there, first of all, you want to make sure that it's actually a UVC system. As I said at the start of my section, UVA does not work. And then the other problem is that you need to have some way of assessing what the dose is going to be. And it's not always kind of easy to know that. Sometimes you can figure it out from the manufacturer, but there, unless you have a radiometer, which is kind of a couple of $1,000, measuring the dose is a little more complicated. Now there are coming out some paper-based dose measurements, almost like a pH paper. And so those are a way of measuring roughly the dose, give or take a few percent. And I think possibly on the IC Tips website, there'll be some link to that. Those are kind of a new product just coming out. And so I don't have any personal experience using it, but that would be something that could be useful to measure a dose for a unit where you're not quite sure what it is. In terms of the heat, that seems like a promising avenue. As I said, you need to be a little careful that you don't overheat the masks. And you also have to be a little careful that you don't underheat them. So you wouldn't want to necessarily stuff a whole bunch of masks in and let it sit for 20 minutes and hope that it got hot enough in the interior of all that pile. So it takes some thought and testing perhaps. The other thing to say about the heating is that the temperatures we're talking about here, like 60 to 70 degrees Celsius, are not sporicidal. And if you are, again, in an environment where C. difficile or other bacterial spores may be a concern, that will not kill them. So UV will kill them, but that temperature will not. So that would be just another thing to think about.
Okay, thank you. I will say, somebody asked, is there a way to get a list of literature references for ultraviolet? So I will remind everybody that at the TIPS website, there's the COVID-19 resource page, and it is updated just constantly. Thank you, Dan, just put it up for you. And so this is just an excellent resource that TIPS has put together, completely free for you. So just keep an eye on that. All the master classes are archived here. You can get all the PowerPoints there.
Yeah, and at the end of my PowerPoint slides, there's a couple of pages of the references that I cited. So,
okay. There are just so many questions coming in. So I just want to remind everybody too, there are so many questions that if we don't get to them all, we will answer them, and those answers will also be posted on the TIPS website for you. So here's a question for you, Bill. Are there any studies representing the surround dosing of ultraviolet?
Yeah, some of the ones that I've reviewed and kind of summarized in my presentation did use dosing from both sides of the mask. Others just dosed from one side of the mask. And so those studies are around. It really comes down to ensuring you get the proper dose throughout the mask, and that is really a sort of a UV engineering problem. And that's why I say that if you're thinking of using UV, you kind of should be in contact with UV suppliers who have that expertise in knowing what their equipment sends out in terms of dose and distance and things like that, and how it may radiate around. So definitely it is doable from either one side or both sides or all the way around, but it needs to be designed properly and set up properly and validated.
Okay. And my last question, I think, for you, Bill, is how should one calculate the strength of UV light based on distance?
That sounds like a simple question, but actually it's extremely difficult. And so that's why I say there are theoretical ways of calculating UV distribution, but they're actually mathematically quite complicated. You're dealing with a 3D geometry. And so I've published papers on this years ago, but it's not something I would recommend anyone try to do. And so the bottom line is that, again, if you're going to set something up, really you need to have a radiometer or one of these newer dosimetry measuring systems to actually measure the intensity at the point where you want to hang a mask or put a mask. That's really the only safe way to do it. There's various calculations you can do to kind of roughly estimate what range it might be, but that's not something I would base a disinfection dosage on.
Okay. I did have a question that I think I'll answer, and then I'll throw it back to you, Bill. The question was, what are the filter layers composed of? Is it the same material in layers? And I would say refer to the manufacturer for that answer. What are your thoughts?
Yeah, definitely. I've seen a little bit of literature that suggests most of the layers are polypropylene, but beyond that, there might be variations among manufacturers that I don't know.
Okay. And so I just want to remind everybody, all the resources are on this page. All the master classes are archived here. And if we don't get to your question, because we knew that it would be just based on response and the emails that I was receiving, that this was going to be a very popular topic, and it is. Last question I think we'll throw out is to you, Bill. How many times would you recommend ultraviolet decontamination? Up to 10, perhaps?
Yeah, that's a tough one because as we see in the literature, you can potentially do it many, many times before you affect the material. But what hasn't been really tested is sort of in a field application where people are actually using the mask between disinfections. And so my concern is that as material builds up in the filter, you'll start to get more and more airflow resistance. And so at this point, I don't know how many times you can continue using a mask and disinfecting it and reusing it. And I think, Katie, your suggestion that you suggested, was it a maximum of 5 you've seen around? So that might be a good basis just from a usability point of view, rather than the UV disinfection being the issue.
Thank you, Bill. So I would say my takeaway from today is to wear my mask as long as it's not visibly soiled, that it fits properly, the straps are not stretched, then safe reuses, as long as it's stored properly. Those would be very important considerations to reusing a mask. The fit is just so very important for proper function.
Yeah, I think that's probably the bottom line. If it doesn't fit, then it doesn't help much.
There you go. Well, we just want to thank everyone. And again, we will get to your question and it will be available on the TIPS website. Check out that website. Michael is working around the clock to keep this up to date. He's doing an awesome job. And thank you for your suggestions. We'll look at those. And again, just thank you to Curcia and TIPS for putting this together in a very short time, just based on the passionate emails that I've received and me sharing my concerns with them. Thank you, Bill. And thank you all for attending today. Remember, join us April 16th at noon Eastern Daylight Time And that webinar topic will be, what are you bringing home? So I hope to see you there. Thank you all very much.
Thank you.